Hello and welcome to our review of the lupus literature for August. We record these podcasts for you every month, so you'll always be able to keep up to date on the latest literature and expert opinions. I'm Ed Vitale. I'm chair of the Lupus Forum. I work at the University of Leeds in the UK. And today I'm joined by Dr. Antony Psarras, who's NIHR academic clinical lecturer in rheumatology at the University of Oxford and the Kennedy Institute of Rheumatology. Welcome, Antony.
Thank you, Ed, for the invitation.
Okay, so today we're looking at the key publications from August, and we've chosen two papers for discussion today. They're both related to lupus nephritis. So the first one I'm going to have a chat through, which is a paper in Rheumatology about tapering of therapy, and then you're going to tell us one about a potential new biomarker. Okay, so this is a paper by a Greek group led by Maria Tektonidou about tapering therapy with lupus nephritis. So this is a subject that comes up a lot. It's a big question for patients and physicians, and we've seen one or two papers about this before that we've discussed on the forum. And the basic issue is that we've got some quite well-established treatment regimens to induce remission in lupus nephritis. We've got the evidence that mycophenolate is probably the standard long-term maintenance agent to maintain a remission, but how long do you have to stay on it? Is there a point at which you can stop it and minimize risks? So after initial remission induction in lupus nephritis, flares do occur, something like they quoted in this paper, 8% at 1 year, 48% at 10 years. And if you stop immunosuppressants, that's something like 18 to 38% of patients will have a flare. If they have a flare, it's kind of bad news because you can obviously restart induction therapy, but there's lots of problems have been accumulated even if you do restart. So the outcome of induction therapy on a second episode is not as good as the first. And these relapses are associated with worse long-term kidney survival and worse health-related quality of life and socioeconomic impact, and all aspects of disease are more problematic. There's more glucocorticoid exposure, etc. We also know, there was another paper we reviewed recently, that a study called Win Lupus was a randomized study where patients were randomized to either stop or continue immunosuppression. And it showed that stopping at 2 to 3 years led to an increased risk of flare, quite significantly so. Even though the study didn't have that many patients, they could see a reasonably large effect. So we know that's too short, but we don't know, for everyone at least, but we don't know what's the right amount. And the EULAR guidelines allude to this, saying that in remission therapy, that if remission maintenance should be done for at least 3 years, but a lot of people will treat with a lot longer. So this was a study that was trying to look at this question in patients in a lupus nephritis cohort done from 2 centres, where a really nice thing I thought about this study is they've been prospectively collecting data every 3 months up to 6 years follow-up with extra data collected around the time of tapering decisions. So it's a well-collected cohort of patients. They had 142 lupus nephritis patients. They excluded, for a few reasons, those with end-stage renal failure, patients who were only being treated with steroids for some reason. All these patients are class 3, 4, and 5 nephritis, the types that we worry about. And then of those, they evaluated patients who had tapered their immunosuppression, meaning not just the hydroxychloroquine and the glucocorticoids, the actual azathioprine, mycophenolate, etc., who tapered their immunosuppression because of stable disease. If they were coming off drugs because of toxicity or something, that wasn't the issue here. So there were 111 people in the cohort who had done these attempted tapers. That occurred at a median of 34 months, although with quite a range around the time. At the time of tapering, the data they show suggests these patients were doing well. So they had a 24-hour protein of 0.17 grams, eGFR 110, 61% on hydroxychloroquine. One thing I noticed interestingly, 45% were off their glucocorticoids at the time of the taper, which means a lot of people were still on some steroids, even though they were tapering them. Maybe not the way around I would have done it. But anyway, that's the data. Most of them were in remission. So what did they find? They found that 19 patients, 17% of them, had a flare during the taper, as in while the doses were coming down. 11 of those flares were renal, of which 10 were proliferative. The others were in other organs, CNS, myositis, arthritis, quite commonly. Most of them were put back on therapy. Most commonly, it was cyclophosphamide, and they said that the patients who restarted with those therapies like cyclophosphamide got back into remission again. What predicted the risk of a flare? Having had a previous flare, having a higher SLEDAI, not being on hydroxychloroquine, or still being on glucocorticoids. Interestingly, I mean, those things all make sense, but interestingly, one thing they didn't find was associated with flare was things like duration since the initial episode or time on immunosuppression. So they're much more about the quality of the remission rather than just pure time on treatment. They also did another analysis of people who had flares at later time points, like after they'd tapered, whether sometime later. The messages they found were quite similar. Again, hydroxychloroquine was offering some protection. Higher SLEDAI was a bad thing. Okay, so then lastly, they also looked at the long-term outcomes of these patients. So at the longest follow-up they had, and here this is a median of 124 months, so 10 years of follow-up. They also looked at who had the best long-term outcomes. Interestingly, well, perhaps it makes sense, but the people who had tapered their immunosuppressants actually had better long-term outcomes. Now, obviously, I don't suppose that means that immunosuppressants are bad for your long-term outcome. It more indicates that the treatment decisions were being made sort of sensibly and carefully in the right people. So that suggested to me that just the importance of good management. If you make careful decisions, you know when someone's doing well, and you taper their immunosuppression, you can get it right. And that is somebody who did well. On the contrary, the people who got the worst long-term outcomes were the ones who'd had a flare. Okay, so what was my view of this paper overall? I think there are some things that are a little bit difficult to unpick. They put in quite a bit of detail, if you look at the paper, about how they tried to do different multivariable models for different questions, which I haven't got time to go through all of those today. But there are some things that are a little bit difficult to say what's cause and effect. People doing well, therefore you tapered, therefore they kept on doing well. You don't entirely know whether it's the doctor identifying the good patient, or that there are phases of the disease where the treatment doesn't matter. Some of these things are a little bit difficult to understand, but there were some things that I thought were quite clearly stated. One is clearly that there are quite a lot of people who can taper successfully. That's just important, I think. So at a not too long, median 34 months when the tapers occurred, a lot of them were very successful. So it can be done correctly. I liked their message that it's all about the exact situation, like the quality of the remission, the combination of therapy is more important than just pure time. So having got an earlier kidney response, having a lower SLEDAI score, continuing hydroxychloroquine, these were all things that told you someone was going to do well. It's not just how long you've been on therapy. That's what this one suggested. Other studies have put more emphasis on time. A lot of the flares were during the tapering. So I think that's quite an important message as well, that, if you're going to attempt to taper, you do it in the right person and you observe carefully while you're doing it. Those who tapered successfully, their long-term outcome was good. That was fine. Those who had a flare, you could recover it with repeat remission induction, but it is associated with the worst long-term outcome. So I think there's a few interesting messages there. But I think this question about exactly how to taper immunosuppression remains quite a complicated one that takes quite a bit of skill on the part of the doctor. What did you think about that one?
So thank you, Ed, for the detailed presentation of the paper. So I overall, I think I agree with you. I think it is, first of all, the authors try to answer a very important question in management of lupus nephritis. Okay, so we currently we have the induction treatment. So it's either cyclophosphamide or mycophenolate plus minus a calcineurin inhibitor. And then we have the maintenance treatment, but when shall we stop immunosuppression? So it is one question I would like to ask you, since you have seen the data a little bit more carefully. So is this cohort pure lupus nephritis, or the patients had also extrarenal disease?
Some of them had extrarenal disease as well, but the entry criterion for the cohort was lupus nephritis. And some of the relapses they had were extrarenal as well. That's another important point.
Because
So you might say, if you've got a relapse, but it's arthritis and you just had to restart therapy, but you didn't have a renal relapse, that's not too different. That's a more reasonable risk to take, isn't it?
I mean, that might have influence, for example, the dose and the tapering of the glucocorticoid use as well. But the other comment I would like to make, so this is a Greek study, and so the population must have been quite homogeneous, white Caucasian.
Good point. Yeah, that's a very important point. Yeah, that lupus nephritis has a tendency to be a bit milder in these patients. So yeah, in groups of patients like people with African ancestry or East Asian ancestry, lupus nephritis is more common, a bit more severe, can be less responsive to some therapies. So yeah, that is a good point. Yeah. I think we have to be careful sometimes about extrapolating from one population to another. Another one, actually, when you mention about where the cohort was done, is that this, as is shown on the slide, this goes back to 1992. Which is great. It's great to have really long-term follow-up, but the therapies they used were a bit different. So less rituximab, less mycophenolate, more cycloaza, which may be different in other contexts.
Yeah, it is. So it's like if we can draw a conclusion from this paper in particular and other studies, is that actually it is important the induction treatment to be quite thorough. So, and we should aim for complete remission in 12 months, as this will probably predict a better outcome for the patient. Also, I think the paper highlights the importance of maintenance therapy with hydroxychloroquine. And I think there are studies now that have also highlighted the importance of dosing hydroxychloroquine at 5 milligram per kg, as lower doses carry the risk of a flare over the subsequent years. And yeah. So, and I think that would be a very good method, so we can discuss the following paper, which is all about predicting flares in patients with lupus nephritis.
Okay, so let's go on to that paper. Okay, so this paper's titled CD163 as a liquid biomarker in lupus nephritis.
Right. Thank you, Ed. This study by Renaud et al. So they tried to answer a very crucial question in management of lupus nephritis. How can we actually skip the kidney biopsy in predicting a flare for the disease? So the group actually recruited 237 lupus patients who were retrospectively selected to test the added value to explore the urinary biomarker, the soluble CD163, as what we call liquid kidney biopsy biomarker, in a larger panel of serological urinary biomarkers for lupus nephritis and systemic lupus erythematosus. So just to mention what CD163 is, this is a receptor for hemoglobin, haptoglobin, and is mainly expressed in myeloid cells such as neutrophils. So actually, the authors tested all these biomarkers for their capacity to discriminate against active lupus nephritis and for the performance to explore active or chronic disease and variations during the follow-up of the patients. So the authors tested, as we said, a lot of biomarkers, including different autoantibodies and anti-dsDNA, anti-Smith, complement C3 and C4, anti-C1q antibodies, as well as the protein creatinine ratio and the CD163 creatinine ratio as well. So as we can see in the figure to the right, so it was only the ratio of CD163 and creatinine, as well as the protein creatinine ratio, that were strongly associated with the SLEDAI score, whilst most of the biomarkers, including the ratio of CD163 and creatinine, was poorly correlated with the value of eGFR. So the key result of this paper was that actually they found a strong correlation between the spot PCR and urinary ratio, CD163 and creatinine, in patients with active lupus nephritis, but not in patients with lupus nephritis in remission or patients with lupus without lupus nephritis. And this biomarker in particular, they commented on the discussion that they couldn't discriminate lupus nephritis in remission from non-renal lupus. And 4 other serological biomarkers, but no URI parameters, exhibited good performance in discriminate proliferative class 3, 4, plus 5 active lupus nephritis from isolated membranous class 5 active lupus nephritis. So, and I think there has been a lot of discussion recently from many groups about how we can, what are the best biomarker we can use in the urine to assess the inflammatory activity within the kidney. Because actually there was a big study from Argentina showing that even the urinary sediment, the presence of hematuria or proteinuria in patients with lupus nephritis after induction maintenance treatment does not correlate very well with the kidney biopsy. So the patients may actually have inflammatory kidney lesions, and that may not be reflected in the simple urine dip.
I remember this paper. We discussed this one on the forum as well with Brad Rovin, and there were patients who were thought clinically to be doing really well, but they were having repeat biopsies that sometimes still showed inflammation. Yeah.
Exactly. So that actually highlights the question, in my opinion, can we stop immunosuppression in patients who do not have urinary sediment anymore?
Yeah.
So,
there's still histological inflammation in some of those people that were stopping, like in the previous paper.
Yeah, absolutely. So this paper tries now to find that if we use this urinary CD163 creatinine ratio, may provide an additional parameter for monitoring lupus nephritis patients. So again, I think other studies have to be performed to test the results, and I think in particular there is no validation cohort for the biomarker. Is that correct?
That's right, yeah.
So that could be another limitation that perhaps other groups will need to apply the suggested biomarker to their cohorts and see if they can produce the same results. So what is your view on this work?
Exactly. I do think it's promising. I think I found it, I've always asked myself for years why we just look at the total amount of protein or the total amount of albumin to assess lupus nephritis when there ought to be. You would think that there should be so many other easy to use biomarkers to be found in urine. And so I found it very promising that I thought their analyses were quite detailed. And I liked the comparison. You said, they chose the right control groups, didn't they? So it seems like a very promising biomarker. But as you say, we need, there's a pipeline of biomarkers, isn't there, going from concept and discovery of what might be an interesting molecule to then a study like this where you show it's associated with the outcome of interest. And then, as you say, you need certain types of validation that probably some of that work is still needing to be done, like replication of a cohort is one. Also, the amount of added value over clinical decisions that you would have made with or without the biomarker, how that would have looked. And ultimately, even in an ideal world, would be to say, if I treat people according to this biomarker, can I get a better outcome than if I treat people without using it? And that's an awful lot for me to ask for. And we don't always get all of that validation for every biomarkers that we see. So I do think it's very promising. There's probably a little bit more we need to know before we'll start being able to use it in the clinics, I think.
So exactly, because I think another issue I'd like to highlight is that, okay, we use proteinuria as to assess the patients every time they come in the clinic, but actually we can distinguish, we cannot discriminate a flare of lupus nephritis or chronic damage in the kidney based on proteinuria. And another issue is, for example, is in class 5 membranous nephritis. So we know that the patients tend to respond more slowly to treatment, so they may have prolonged proteinuria that actually will not be able to assess if the patient are responding to the treatment we have decided to give. So
maybe one thing just to bring these two papers together a little bit is just to comment that there's quite a bit of change in therapy for lupus nephritis going on at the moment. We've had belimumab evidence. We've got voclosporin licensed as well for lupus nephritis. There's a few other trials coming in the next year or two that are going to be reporting, like obinutuzumab, for example. So things are changing quite a bit in lupus nephritis. So knowing whether you've got the highest quality, so we're going to start seeing everybody on combination drugs. Combination drugs are more expensive and more burdensome for patients, and we want to reduce things. So you might want to use lots of drugs at the start because that's more effective, but then you want to reduce those down as the patient is getting better. And we need these kind of ways of making these decisions are becoming more important as we have more. It's great to have more options, but when you have more options, you've got more decisions and choices to make. And the other one that will be important is like belimumab seems great at maintaining a remission in lupus nephritis. It helps stop flares longer down the line, but then people will definitely ask, how long do I need to use this sort of higher cost drug? They might ask something like, actually, can I stop my mycophenolate and just continue the belimumab? There's a lot of change in the air, and having the tools to make these decisions is going to become more and more important.
Yeah, absolutely. Absolutely. This is a great message that combines both papers and highlights future work to be done.
So I think that's all we've got time for today. Thank you for joining me, Antony. It's great to hear your views on the latest developments in lupus nephritis management.
Yeah. Thank you, Ed, for the invitation.
And thank you, everyone, for listening. As always, you can find the slide decks for these papers at lupus-forum.com. The Lupus Forum is free to access. All our content is free to download, and you can use these PowerPoints in your own teaching and your journal clubs. Don't forget to register for updates on the Lupus Forum. You'll get emails when there's new content like this that becomes available. And you can also follow us, Lupus Forum, all one word, on Twitter and LinkedIn. Thanks again, and see you next time.